Good morning and welcome to our live sessions. I am Jihad Mustafa and I have the privilege today to be joined by my colleagues, Dr. Jaff, Dr. Adam, and Dr. Ansel. Today we're going to be talking about the effect of Paclitaxel on patients with PAD, a review of current literature and best practices. I'm going to go ahead and do a quick analysis of the Katsanos paper, looking at a mortality increase in patients receiving Paclitaxel, journal review, and some commentaries. Disclosure. So the learner objective is to review the recent findings and literature, mechanism of action, benefits, and risks of Paclitaxel. We're going to discuss the safety considerations in PAD applications, also evaluate the facts, and make necessary adjustments to practices. So starting with the meta-analysis published by Katsanos and his colleagues, looking at the association between paclitaxels and death. In their paper, they reported an increased risk of death at 2 years and beyond with paclitaxel-coated devices for the treatment of femoral popliteal disease. The authors raised concern that a therapy commonly perceived as safe therapy may actually increase the mortality risks. We appreciate that the authors published raw data used in their analysis, which provides transparency regarding their data extractions and analysis methods. For each treatment group, mortality rates were calculated as a total number of observed death divided by total number enrolled patients. Also the metrics such as number of withdrawals, number of patients remaining at risk, and time of death were not considered in these calculations, and this is hopefully something we can discuss in more details. The mortality rates drawn from time to event data, such as with Kaplan-Meier methods, are preferred in meta-analyses, and we didn't see that here. And methods exist to obtain these data even when only crude mortality rates are provided in the original articles. An example illustrating how the choice of analysis method may impact meta-analysis conclusions follows. So looking at one of the figures from the meta-analysis here, in figure 3, the authors reported 5-year mortality rate of 14% by dividing 42 mortality by 297 with paclitaxel-coated devices, and 7%, again, dividing 12 by 177 with controls in the Silver PTX trial, representing approximately twofold increase in mortality risk for the paclitaxel group. So if you look at the thunder and the impact actually crossing the risk ratio, in order to get a more reasonable statistical difference, actually combined the entire cohort together, so the risk ratio went to the right and became more statistically significant. So in the original Silver PTX article, the 5-year mortality rate calculated with time-to-event method, and this is what we mentioned earlier, was reported as 10% with the paclitaxel-coated devices and 17% with the controls. It's an opposite results in favor of the paclitaxel. So if you were to combine this here, probably you would get a different overall cohorts. It is, therefore, seems plausible that similar discrepancies between crude versus time-to-event mortality rates may exist among other studies, including in the meta-analyses, particularly those with longer follow-up periods during which higher rates of patients' withdrawal might be expected. It would be interesting to reanalyze the meta-analysis findings using mortality rates derived using time-to-event methods to assess whether the conclusion of increased mortality risk with paclitaxel-coated devices is confirmed or refuted. It is therefore seems plausible that similar discrepancies between crude versus time-to-event mortality rates may exist among other studies, including in the meta-analyses, particularly those with longer follow-up periods during which higher rates of patients' withdrawal might be expected. Additionally, potential mechanism by which paclitaxel might contribute to excess mortality should be explored, given that the cause of late death were mostly unreported or deemed unrelated to the device or procedure. And these are some of the references that were used. I'm going to hand it over to my colleague, Dr. Jaff. But before I do, Dr. Jaff, you presented a very intriguing slides earlier today showing a few meta-analysis from 2016 showing something completely different. You want to comment on that a little bit?
Yeah, thanks, Dr. Mustafa. It's great to be with you guys. I'm going to show some of that stuff this morning, but it's why I was caught by surprise. I did not anticipate this meta-analysis. I didn't anticipate this finding. Obviously, we all knew that there was a separation of curves in the IMPACT randomized study at 2 years. I think everybody took that very seriously, but that delta was lost at 5 years, and there was no difference. So I think it's raised a lot of questions. So with that, I'm going to jump right in here and kind of give you my perspective on this. So let's just go back a few weeks, not ancient history, December 6, 2018. I'm standing outside an exam room of a new referral for a second opinion. Patient who had been seen by another vascular specialist in Boston comes to me, just wants to know, this is the story, 68-year-old man, has disabling claudication of the right leg, had been seen by a vascular surgeon about a month before in Boston. He's had 5 years of claudication of the right leg only, but it's gotten significantly worse in the previous 6 months. He's got hypertension, diabetes, and hyperlipidemia. On exam, he's got an excellent femoral pulse on the right, no palpable distal pulses, and his left leg pulses are normal. He's got a resting ankle brachial index of 0.72 on the right, 1.03 on the left. On duplex, we're found to have a 15-centimeter mid-SFA occlusion, great inflow, 2-vessel runoff, kind of a straightforward case. No tricks to this. The vascular surgeon had advised he undergo a Zilver PTX procedure, and he was actually scheduled to have that done a week after he saw me. Now, before I walk in the room, that seems pretty reasonable, right? Zilver PTX, one of the earliest randomized head-to-head trials, taking the Zilver PTX device against PTA, showing superiority in PTA and bare metal stents. So at 12 months, that looked pretty good, right?
Absolutely.
And then 5-year data is published showing similar separation of the curves, showing continued superiority of the Zilver PTX device. So I thought that was a reasonable recommendation by the surgeon. So I'm about to walk in, introduce myself, and unless I found something different, Dr. Mustafa, I was going to say, sounds like a reasonable thing to do.
That's great.
My iPhone buzzes. I pull my phone out of my pocket, and I see this alert from Vascular News, and I read this, and I say, what the heck is this? I didn't anticipate it. And then another one, Endovascular Today puts a bleep out that says that this finding had been published. So since I didn't anticipate this, and I really didn't have an inkling that this existed, I ran back to the computer, and I went to PubMed and just kind of called it up. It's the great thing about the internet. And I found this meta-analysis from 2 years prior that you just mentioned that the same authors had published. 2016, looking at paclitaxel-coated PTA and FEMPOP arteries, and they didn't mention a single thing about mortality risk. The same year, I remember reading this paper, which looked at a similar meta-analysis, and they specifically called out TLR and all-cause mortality in DCBs, and there was no difference. So I was really caught by surprise. Now, you know, in my career, I've worried about mortality risks in other types of endo procedures. So catheter-directed lysis for acute iliofemoral DVT and the risk of breakaway PE, and should you put a filter in before those procedures, right? And obviously the whole thing around IVC filters and strut migration and embolization and that. And then, of course, stent grafts across the popliteal artery and acute thrombosis, limb ischemia, and death. So certainly I've been worried about stuff like this, but I never thought about paclitaxel-coated devices and mortality. So then I went and saw if any experts had come out with any thoughts, and there had been some early comments that have been put out by people I really respect. John Kaufman, a thoughtful interventional radiologist, who said, think about it. Thomas Zeller said, look, this is a premature conclusion to be made, and He's certainly a worldwide recognized expert in the field. Mike Dake, another superstar in the field. And Gary, another guy who I highly regard as someone who looks at data very thoughtfully. And so now I'm standing outside the exam room ready to walk in the room. And so it was a tough discussion. I made sure that it was claudication only, and that although it had gotten worse, it hadn't gotten worse to the point where I thought he was at imminent risk of limb loss. And my answer was to the patient, look, I just got this alert on my phone. I don't really know what it means. You're not in an urgent risk of limb loss, and I think we ought to sit tight for now. Give it a couple of weeks to get the dust to settle, and then we'll kind of revisit this, which is what we did. So I still don't really know if this is real or not. You got to take it seriously, right? We're in this business to do no harm first, and so despite the fact that I think we all agree that there's been a complete evolution in therapy for PAD based on drug-device combination products, you got to be concerned about this.
Absolutely.
I have no doubt that every commercial manufacturer is going to publish its own patient-level results. Each one of those will likely tell their story, but, there will be the bias that they're sponsored by industry, and so, we want some more objective, no-bias data. Gary's going to talk a little bit about this effort to take all of the data on patients in trials for PAD with Paclitaxel-coated devices into one independent database to try and answer the question. I think that's going to be really important. So,
it's a great effort, yeah.
So, Dr. Mustafa, the only two things I can say that bother me about this, aside from the fact that this is disconcerting, is that one, this meta-analysis was leaked to the media before it was published. We are our own worst enemies. We can't do this stuff like that. Mm-hmm. There's a reason for a peer review process. And you're not supposed to be able to read this stuff or talk about it until it's published. And that wasn't the case here. The fact that it was released before it was published led to all sorts of gossip and rumors and a lot of frenzy. So I think that was not great. The second thing is on the paper itself. So if you look at the conclusions of the paper, it says straight out that further investigations are urgently warranted. Frankly, with all the concerns, some of the stuff you pointed out about how this data was collected in meta-analysis, that some of it might not have been exactly accurate, that maybe there are other types of meta-analyses that would have been more up-to-date and accurate, urgently warranted leads to an alert. And from a journal like this, it really set the field on its ear. And so for that, I think urgently was alarmist and contributed to the frenzy that exists today.
So actually, Dr. Jeff, having the word urgently coming from a journal like this, and this question goes as well to the rest of the panel, does that make you feel responsible to jump in and do something? Do you feel obligated that you have to do something to clear the water?
Well, I think we all, whether they had said urgently or not, I think this would have been enough to make us stop and think, is there really an association here between Paclitaxel-coated devices and death? The problem with urgently from a journal like this is that it makes people react in a way that they think is going to protect not necessarily the patients as much as their own interest. And so I think that's a disconcerting thing. And that's led to a lot of issues that we heard about this morning around this field. I don't know what you guys think about it.
Yeah, I think the word choice is probably not the best. It almost indicates that there is harm just from the word that's used. But I agree with Michael completely that what this means from our standpoint is that we need to do our due diligence in making sure that patient-level data is reviewed to make sure that there is no harm. Understanding the impeccable evidence showing the efficacy of biologic devices.
Yeah, and I think that, we really have to be careful because when we talk about protecting the patient, it's also not only from death, but from lack of treatment as well. Right. So when you do this, everybody's definition of urgently is a little different. And the problem I had is that this is a fair, respected journal. One, to allow something like that get published, but two, also to have the review where they didn't bring up the fact that there had been patient-level data that had already been evaluated just to help balance the release of the data. And I agree with you. Patient safety is foremost in our minds and in our actions, or it should be. And the fact that this wasn't brought out, it could actually lead to a much, hyper response that wasn't really necessary at that point in time. Yes, we need to find the answer, but it should have been known as a much more a little bit more balanced data set than was really presented at that point in time.
Dr. Ansel, having said that, and you've been a great thought leader in the field, to be able to correct something like this, to get us back to baseline, basically, where physicians and patients feel comfortable. How much time or what do we have to do to get back to that baseline?
I think you'll hear from George's talk and mine. I think you're going to hear that it's going to take a while because that now it's on us to make sure that we prove yes or no to this situation, and that's the way it should be. It's just if it would have been released a little differently, we probably could have done it in a little less time restrained, time to feel forced to just hyper timetable with this.
Yeah.
But the thing, one other comment to that is Dr. Ansel had mentioned that it's our choice. With the word choice he used, it's not just our choice. It's how healthcare systems, administrators, policyholders actually interpret what the results were. And so, from our standpoint, if we've got it on our shelf, we can adequately make the choice. But how about if it's not on our shelf because it's removed, because administrators have stated that there's a possible harm and we shouldn't have that technology available, or policymakers come and say, listen, this is not going to be reimbursed because there's a possible indication for harm. So that has to be taken into account.
So George mentioning administrators controlling such thing based on this article. I know many healthcare systems, the administration actually came down and removed the product off the shelf, not the physicians.
That's right.
And there are many physicians right now don't have access to the technology. Are you one of those physicians?
No, we actually do have access, but there are centers or healthcare systems close to me that don't have it. And in this lieu of drug-coated balloons not having a pass-through code, so I think that's also a behavior from an administrator standpoint to say not only are we not getting reimbursed, but now there's possible harm, so it's a little easier to take it off the shelf.
Gary, one more question to you, and we'll move on. Early on today, as we were polling the audience, almost 80% of the physicians in the audience said that they will continue to use the product as of today. And you run also a big healthcare system. Based on that, in your system right now, do you still allow your physicians to use the technology?
Right. So in our healthcare system, the physicians are currently still allowed to do that. It's a personal decision by the practitioner as to how they use it currently. I think that this still is in the realm of, until we have a final answer, it's the individual.
That's great.
Physician's viewpoint.
Michael, how about you?
I guess I would say this. This is no different than any other therapy we as physicians prescribe to our patients. You look at risk versus benefit ratio, period. Mm-hmm. There isn't a single therapy that we can offer that doesn't have some risk, right? Nothing.
Absolutely.
From local anesthetic for a minor procedure that carries some risk to something like this. And at the end of the day, the number of cases was so small.
Yes.
The number of patients who've been treated successfully and followed for long term with no clear signal is so big. Mm-hmm. And it's just a risk-benefit ratio discussion. So, in the patient like the one that I was about to see, so this is somebody who really just wanted to walk more. Didn't need it for a job, wasn't losing income because of it. There was no real urgency to push forward. So, we took a pause. Now, is that different than what I would have done the day before when this paper hadn't been out? Yeah, it is different. But that's our job, to be thoughtful and to do no harm, right? But if that person had, career-limiting claudication, would I have let that person go through? Absolutely. If the person had CLI, where you needed some durable patency in order to get the foot to heal and salvage a limb or get an amputation site at a toe to heal, absolutely, I'd go ahead now and do it, because that's the most effective category of therapy we have. It's all risk versus benefit.
This is really an excellent explanation, Michael. Thank you for bringing that to light. Great.
Perfect. Jihad, I'm going to talk a little bit about, just as Dr. Jass stated, understanding what's been presented thus far. Will it make a change in my practice? And simplistically, in my mind, this is the way I think about it, especially just coming back from Link and understanding the presentations thus far at ICET and what's been published to date and prior experience. So as a physician scientist, in the bottom left of this triangle, that's understanding that data, understanding that Paclitaxel has been used on devices far in the past, such as drug-eluting stents in the coronaries, for example. Also understanding data that has been presented at Link, and Dr. Ansel is going to go into the specifics of that, but 3 drug-coated balloon companies and 2 drug-eluting stent companies that use Paclitaxel more or less presented their patient-level data after re-going back into the data before January because of regulatory body askings to show their data, and what they showed more or less was that it was safe. There was not a mortality hazard. In addition, on the other hand, understanding the efficacy that has been well served and well shown in terms of patency and TLR, target lesion restenosis.
Yes.
So in regards to the other 2 tiers of this triangle, patients and the clinical physician, I'm reassured in stating that this is still a good technology and we should not pause in using it to date. However, we still need to do our due diligence, understanding that there has been a possible hazard shown. What are y'all's thoughts in terms of this triangle? You agree? Or?
That was the big thing from my standpoint, is that when you look at the mortality rates for the different trials, I went actually to the literature early on before it actually got into this talk and just said, well, what is it on the other different devices? And it wasn't, for me, way out of bounds. It wasn't something that was going to throw a red flag up. But I also said, you know what, still, 2 trials had a little bit of trend like that. I don't think it's Paclitaxel, but is it something else too? I mean, so there's a lot of questions with that it brings to date that we as you said, scientists and clinical physicians for the patient need to be starting to address.
That's excellent.
I like the way you put this. You looked at this on behalf of your patients from a data standpoint and a data integrity, and then you looked at it as the clinician who's sitting there with the patient trying to do what you think is best, taking into account that every option you have carries some degree of risk. I think that's exactly the right way to do it.
Jihad?
This is great, Georgia. It kind of brings us to the real world that we live in, explain to our patients what we just heard and how we're going to use it. The one thing that could be difficult is patients that are not going to be able to understand or comprehend in details what you're trying to explain. And those patients might actually, like Michael said, might benefit from a silver VTX stent. But you mentioned the word, there's a trial that's showing a chance of increased mortality in the layman's terms, but it's not very concerning or worrisome. I think once they hear that word, mortality, they stick with it, and we've seen that in few patients, but the rest of the patients do well. Have you seen any of your patients say no, and then some say yes?
I think there are patients that are hesitant toward an invasive procedure.
Right.
Now this helps foster a reason of why they may not want to pursue an invasive strategy, and they're very educated, and I can't judge them for not pursuing until the verdict is out, in terms of until all the data is out, such that we can make the best decision.
So this is great for claudicant patients, right? Time allows to wait. What about patients in your practice right now that have more urgent situations that you have to deal with? Are you replacing, for those patients that say no to drug-eluting technology, are you doing something else instead? And moving on.
Yeah, exactly. So I think Michael put it very eloquently earlier. We deal with this type of situation commonly. Let me give you an example. Statins, right? A lot of evidence. We know the beneficial effects of statins, but there's been papers showing loss of memory, leg pain, et cetera, that's been attributed to statins. This is very similar. We try to offer the best strategy, treatment strategies for the patient, and ultimately it's their choice. So at the end of the day, if they say they would like to pursue, then we're happy to do it. But at the end of the day, if they say, listen, we'd rather pause or not use that therapy, we have to oblige by their wishes.
But let me ask the three of you, since you do these procedures all the time, take a patient with critical limb ischemia, where you got to do something, right? So if you say to the patient, look, in my estimation, based on the anatomy you have and the problem we're trying to solve, a drug-device combination product is the right thing to do. And the patient says, I hear you, doc, but I'm not comfortable with it based on this meta-analysis. Odds are you do a procedure that's not with the technology you thought would be best to promote durability so they could get their foot to heal, right? Then you got to come back and do another procedure because that first one didn't work. I think we would all agree that every time you have to go back in, the procedure gets harder, risks go up, the costs skyrocket, and the outcomes are not quite as good, right? Add diabetes to it, then that risk goes way, way high for adverse outcomes. I think those are the kinds of discussions you got to have with your patients.
You're right, absolutely. And Michael, I think that takes us to the second piece of making this choice, right? So I've put together another triangle, right? So in the past, as Gary said, we have to sit here and make the best choice for the patient, but I think it's bigger than that, right? So when you ask questions, or if you're going to answer or respond to Dr. Katsanos regarding this paper, I think it takes a team approach, right? A collaborative effort between industry, physicians, and administrators to do their due diligence to adequately answer the question and understand the question, right? So it's a different paradigm. We've been criticized in the past by our associations with industry, for example, or on the other hand of the triangle, administrators more or less dictating or recommending how physicians practice, and they've not gone to medical school. So I would like to propose and get your opinion that maybe the paradigm should shift in terms of a collaborative effort where industry, physicians, and healthcare providers or healthcare administrators work together to answer questions to promote the best treatment strategies for our patients. Because at the end of the day, if we don't collaborate, then as you can see by this slide, other bodies, healthcare policy, for example, the FDA, is going to make that decision for us, and we won't have a choice. What are your thoughts?
So Gary, you're going to be leading us at this upcoming meeting soon. And George, you bring in industry in combination with physicians and administrators. It just seems a little bit worrisome because it's been viewed in the past as a negative thing. And with the current situation, Gary, do you think, is that an exception for us to do?
I think that, when you look at just your treatment pattern, period, there has to be that relationship that George is talking about, because if they're creating devices without the input of physicians and patient care, it's in a silo, blinded, you're not going to make good decisions. If physicians are making their therapy decisions without knowing the true outcomes of these devices, it's not a good situation. And the administration, hopefully their role is to make sure that we're able to afford and deliver that care in a satisfactory methodology to the patient and to the physician. So that combination, without a doubt, has to be there. And they all have to be weighing, number one, the benefit to the patient. Do no harm and then do benefit. If any of those things are not in there, then it all breaks down. And like you said, though, agency's main, mantra is be safe and effective. That's what they're going to head to, and they're going to hedge towards safety. And it'll be tough for them because policy is always very broad, but application can be very difficult on a patient level. And so it does take, a lot of work together to understand that.
Yeah. And George, I'm definitely on board in terms of collaborations and having a complete multidisciplinary approach to this situation that includes anyone that can help resolve this issue as soon as possible.
Yeah. And Gary, it's refreshing, some of this is already taking place. For example, the Viva physicians asking for the data from industry to analyze it as a third party, working together such that people can make adequate choices and understand the data such that their bias is not eliminated, but decreased. So I think that collaborative approach is beneficial, and that's the way we should approach it.
We're all looking forward to that, and the fact that Viva is leading that role makes it more kosher, and actually very kosher. There's a separate party, number one, leading that cause, and then another tertiary party is going to be analyzing the data. So really, almost like it puts the industry far away from the data and lets us make the decision.
Right, and even though Viva is a not-for-profit organization, we wanted it to be even another level higher. So we're bringing in physicians that are not Viva physicians, and the actual Vascular Leaders Forum will be led by 2 physicians that do not have any industry ties to make sure that we're keeping it as above board as possible. The plan paper would be first authored by a non-industry related physician. And then even the data, even though we're bringing it together, we're helping just to manage it. We're going to bring in an independent statistical group that have to supply RFP to really try to get this done in the best method as possible. So industry can have input in the discussions, but in the evaluation, to be totally as clean as possible, we're going to have them out of that.
This is great, and it really seems like the right thing to do. Absolutely.
And just to reemphasize, if we don't do this, then we may not have the tools to adequately treat our patients, and we could cause harm by not having those tools available. Right. And Gary, or Dr. Ansel, you have seen this otherwise. You led a task force looking to gain reimbursement, that pass-through code for drug-coated balloons. You've shown very eloquently all the data in terms of the efficacy of devices, and if you don't have healthcare administrators and the policymakers on board to get reimbursement, for example, then we may not have these tools to treat these patients.
Absolutely.
So it's great.
One more question is that Gary and actually Dr. Jeff and Dr. Ansel, historically you've gone through other maybe hiccups like this in the past, and time from events coming to light and reaction from you to get into the policymakers, FDA or CMS. What in other events? Give us an example. What time frame did it take you from learning about the events until you got to the FDA and discuss such issues?
I have to lead off by saying that in my career, I've not seen a single manuscript impact the field that I'm involved in as dramatically as this one has. It has been all-consuming from every aspect. So I don't really have a scenario that I can compare to. But let's take, for example, the whole COX-2 inhibitors and cardiovascular mortality rate, right? That was a huge deal. Mm-hmm. Figured it out, right? We modified our practice patterns, did what we thought was right. Data ended up supporting it, and we did it. Statins, George mentioned statins before. The latest concern on statins is the associated potential risk of causing diabetes. So does that mean that we're going to stop using statins despite the hundreds of thousands of patients who have shown dramatic reduction in cardiovascular events? Absolutely. Because of early data suggesting that it causes diabetes? So I think people are appropriately thinking about that, but still using the preponderance of the evidence. In this particular case, I'm with you. There's an urgent need to get to the answer to this. I'm bringing back the word urgent deliberately.
Yes.
But the answer now, the reason it's urgent now is exactly what Dr. Adams said. If these devices turn out not to have a mortality risk, and we no longer use them in patients, then patients with critical ischemia will likely be disadvantaged in their outcomes, and they can't afford it.
Yes.
You know better than anybody, being the leader you are, that CLI patients are disadvantaged to begin with. So
Yeah,
now you can't use optimal therapy or the therapy that we think is best now because of data that turns out maybe not to be the case. That would be just as bad, if not worse, than what's happened so far.
Yeah.
So there is a time-sensitive issue. But as Dr. Ansel said, this is going to take time. There's a lot of data that's got to be analyzed. It's going to have to go through a number of different mechanisms through statisticians to see which is the most valid. And then an independent group's going to have to review all this data and come to conclusions. Then the paper's got to get written. I mean, this takes time.
Absolutely.
It's not going to be a quick fix.
No, it's not at all. I just was going to compliment the leadership that's been provided by Viva by taking this from the time of inception to the meeting that is scheduled. It was, in my opinion, it's not a long time, and it's actually being done in a short period of time. Everything is being condensed and done appropriately. So Dr. Ansel, in your opinion, the work and effort that you put into this, is that beyond anything else you've done in the past?
Yeah, I'll agree with Dr. Jeff. I think this has probably dominated my life more than any single thing in my career as far as trying to do this in a time-expedited fashion. It's a really big deal. I mean, it's to all the points you guys have already made. It's not just the potential of a risk of the device, it's a potential risk of not using the device.
Yes.
And, trying to give the everyday physician who's out there practicing on the front lines, some data that he can help use to make his decisions. We're the patient advocates.
Yes.
And all these other, components of this, that's not their mantra. We are. And so we have to do this, and if we don't, shame on us, because we're the patient advocates, we're the physician providers for this, and we need to make sure that we're doing this in the proper format.
And taking this another step, Jihad, looking at maybe a good thing that comes from this is that when Dr. Ansel and colleagues look at all the data, we may see that it's not a black and white. Maybe it's a personalized approach. Dr. Jaff mentioned that there's some data where there is a splay at mortality at 2 years. Maybe it's a certain patient population that's driving that effect. And when Dr. Ansel looks at the data, he can give me advice to say, George, in 50-year-old women who are diabetics, for example, whatever comorbidity, gender, whatever that may be, that maybe this isn't the best strategy at this point in time. But for this patient population, this is the best strategy.
And it may be even more complex than that, because think about it. Right now, we can't figure out a way that the chemical's doing that. We're going to look at it really closely. But it was jumped to the conclusion that it's the chemical. These were unblinded trials. It could have been our response. It could have been the patient response. All of a sudden, because when you first hear about it, you go, what? The patients I don't have to treat as much have a worse outcome? That it just kind of clanked in your thought process. But then when you step back and say, but let's look at this again, now you start saying, well, so why could this have happened? Why did we see a trend, at least in a couple trials? What were we missing? So this is an opportunity. You're absolutely correct.
That's right. And so with mine, I found this quote by Mark Twain that I think sort of sums it up. So to stand still is to fall behind. And with that, I'm going to turn it over to Dr. Ansel.
Thanks, George. So we're going to start with the effect of paclitaxel on patients with peripheral arterial disease, a regulatory perspective. Industry is doing their due diligence, as you would be if this was your car that was saying that it was having brake failure or anything like that and not proven. You're going to go back and look at your models. So, Impact Randomized has, already looked at that. They've had CEC adjudication, and Medtronic has now gone and actually combined all their different large data sets to try to see if there's any trends. This actually becomes very important as we look for dose response, because now we have bigger numbers, can look for that. ZovaDX did the same thing. They had that trend, not statistically significant, but they looked back to say, to a CEC who's independent, and go, can we find something? Was there a smoking gun? Because it can't just be a scattering of things. There should be something that's, some kind of process that's causing this if it's real. And so they're looking at it. Stellarex, doing the same thing. They don't have the 5-year data yet, but they're going to be looking at it after 3 years. You have Lutonix, who's been out longer than anybody, looking at their data sets. And even the new, now coming, recently approved Olivia DES is looking back at their data sets to see if there's anything that they were seeing and didn't recognize or anything like that. So industry is doing their due diligence. It's just none of these trials are powered individually for mortality after that 1-year time frame. So, and it's always what we call post hoc, as you guys know, that you're going back and looking at your own data, and that can create biases as well. So it's good to do this. You have to do it, but it won't be the final answer in this. So what must be evaluated for the data sets? Certainly mortality compared to balloon angioplasty. It's very difficult because the administrators don't get this at all. When I've tried to talk to them about it, they don't get it. And it's because the plain balloon angioplasty was from randomized trials for typically IDE trials, which are very safe, simple patients. And as we got the other data sets, some of those were in registries, which would include patients with sometimes critical limb ischemia, much more complex disease process, which is associated with higher mortality cardiovascular in the first place. We have to look for a dose response. If you're going to look at a drug's efficacy, there should be a dose response. If you reverse that and say, is there an adverse outcome, there should be a dose response to that as well. And as we talked about, other variables that may lead to this imbalance. Did we use better statins? Did we use more antiplatelet therapy? Did we do something on the plain balloon angioplasty because we thought they weren't getting as good a therapy, so we tried to make up for that. And so those kind of things, did the patient, because he was more symptomatic, come back more to the office? All these things that we have to look for at the entire care instead of just saying it's that. Because we've seen this little bit of trend before with other devices. But there's going to be potentially a confounding bias effect. I mean, that larger data sets had all this, so we have to make sure that we're comparing apples to apples and oranges to oranges. Potential variables that could lead to the effect that that we're seeing certainly could be statistical chance, because these are stats and these aren't patient level data. There's lots of different ways to look at them. They are thought to be hypothesis generating, and that's the biggest thing that I think has gotten a little out of control, is that these are just to generate the question. I don't think it should ever say that we need to have an urgent review of something, because it's meant to generate questions that need to be answered, not to make policies on this. The investigator bias of the trials, as we talked about, wasn't blinded. We need to look at Paclitaxel. Is there something that we were missing in all this? It's been around a long time.
Correct, yeah.
But, so is aspirin. And so, sometimes we learn, old dogs can learn new tricks, but we have to look at it again. I do think, like we talked about, the intensive clinical follow-up of symptomatic versus non-symptomatic, the number of repeat procedures. Because when you get a repeat procedure, what my administrator forgets is they get a complete history and physical again. So I might find something that I can prevent their death from a gastrointestinal or other type of malignancy, those kind of things. And we talked about medical therapy. And others, we just don't know. Was there something else that we weren't doing equally between these two groups? The other thing we didn't really deal with, and either does any of this is from their initial treatment. So what happened later down the road? Did they not get drug therapy later on? So this, muddies a lot of the waters that we're going to have to clear up, because this is a very complex data set to really evaluate.
Who would know, Dr. Ansel? I mean, how can you really pick what happened down the road?
Well, it's a really good question. So some of the studies will know that. They'll know how they got treated. Hopefully in this blinded data set, we're going to get some of this information. But I'm not sure even that just this one data set is the full answer, because we may need to go into the Medicare databases, AHRQ, VQI. There may be other ways to figure this out. And actually, to your point, Dr. Adams, this is a really good exercise, because we may learn a lot as we do this on how we should be redesigning our trials in the future to make sure we're covering our bases for all of this.
Yeah.
Good question. As you guys have mentioned, Viva, which is a not-for-profit 501(c) group that is really dedicated to education and research, is coordinating a evaluation. It's not our evaluation. We're just coordinating it. We're going to be bringing in internationally renowned physicians, statisticians, oncologists, people from regulatory and industry to come together to look at all these questions, have big-time discussions, and in fact, the presentations are kind of entry. It's the over 4 hours of discussion that's over a day and a half that's going to be the real meat of this, to come up with hopefully a paper that can give guidance as to how we move forward with this. What kind of questions do we need to have answered? What kind of questions should we even be asking? And is there something else? Always ask people that you don't know. Yeah. We're inviting patient advocates, because the patients may have a totally different viewpoint of this that we might be missing as the caregiver. The person who's getting that care may say, well, what about this? And we wouldn't have even thought about it. So we're trying to do all that. But we want to develop a plan to go forward that'll best ensure the safety for the patient as well as good treatment. This will hopefully present a plan for industry-wide patient-level analysis that we talked about, getting all their data and having this group, not just one little group come up with it, but a large group of international experts help develop those questions we really want to look at before we start to look at the numbers. Because we don't want to go back at it and say, well, what about this if we didn't like the answer? We got to come up with all the questions ahead of time. Regulatory plan, certainly they've asked for patient-level data from industry. I know they're in a second round of requests. They're going to be looking at all this data independently as well. So it'll be a really good thing to see how regulatory looks at it, how independent physicians look at it, to see if we come up with the same conclusions. Did we ask the same questions or what? But hopefully they're very complementary, because there's going to be free communication, at least the Vascular Leaders Forum, between regulatory physicians and industry to kind of have these questions ahead of time. Yeah. They've already come up with a letter that says the bulk of the information should allow you to still use the device. They did not come out and say that you should be pulling them off. I think that for the physicians, if your administrators have pulled these off the shelf, you should be showing them this, because that to me is an administrative decision that may not be wise, because now I know they're worried about the risk medical legally. Of which we'll have a lawyer at the VLF too, because we need to have that kind of input. But there's also the risk of not treating the patient, as we've discussed earlier. And then, as you see, there's the letter that they put out. So there's just the heading, and then that's the letter, so people have that on their slides if they want to look at it. This is the FDA current FDA regulatory plan that they're going to be proceeding forward with, which is getting all the patient-level data. Now, they won't be blinded. They're not going to blind that data, so they're going to be looking at it. And they might have to ask industry to get more uniform definitions, because certainly if we were going to do that, that's one of the first sets that you have to do, is how are we going to use the same definition. So we all know that in many peripheral trials, calcification may be defined differently by all the different trials. So if they're going to really look at that, if we're going to look at this, we're going to have to try to come up with universal definitions and apply those definitions to the data sets themselves.
So the complexity of this is actually beyond
it's not a minor, like you said, it's not a minor undertaking, that's for sure.
Just want to make sure that everyone knows how much work is being put through the Viva group leading this, along with the other physicians that are joining you. It's a huge task.
To Michael's point, when you do this not in an optimal fashion, when you raise the alarm, you've cost a lot more than just money. Industry, without a doubt, is putting millions of dollars towards this effort. Millions of dollars that could have potentially gone to other research efforts. It takes your attention, your researchers away their attention from what they should be doing, which is developing new technologies and new, better treatments, and now we've got to look at this. So, we could have done this just in a little bit, probably more calm fashion, still done it scientifically rigorous, but when we don't do that, it's expensive, and there's consequences beyond the cost of that.
So, you're saying that it could have been done easier. And Dr. Jeff, you raised that point earlier, the frenzy that went on. So if this was published appropriately and it wasn't leaked, you think then it would have been much more controlled, because it got into the physicians first, physicians read it, and then took an action after that? Is that your thought?
I think what would have happened is experts across the field would have gotten together and said, wow, look at this. Let's see if we can get a group together, try and get the companies to provide the data, homogenize it as best we can, and see what answers, and then what other questions we need to ask. And we could have done it very thoughtfully and pragmatically, right? If the conclusion had said, this is hypothesis-generating discussion that warrants further investigation. That's all. That's all it would have said. We would have done it. And Gary's right. I think we will learn how to change trial designs as a result of this analysis. That'll make our trials better. I think that would have been a very thoughtful and pragmatic way to go. Without the frenzy, without the panic, without health systems withdrawing, without news from Europe that they've stopped enrollment in large randomized government-sponsored trials. I just think there would have been a much greater thought and less frenzy around this. One thing I do like about this plan for the March meeting is Gary said a patient will be there. You know, we all know that we've participated in FDA panel discussions where a new product to the market is being considered. They always have patients sitting on the panel. They always have patients testifying, because at the end of the day, that's what we're all here trying to do.
Absolutely, yeah.
So I think it's really smart to have a patient there as well.
That is true. And as this frenzy continues to go on right now, what we've noticed coming from Germany and being here in the U.S., Dr. Hansel, I haven't seen physicians slowing down or the discussion slowing down. In fact, it continues to be chaotic per se. Is there anything that we can do at this point to tell people to calm down a little bit, or just wait till something is being done, such as the March meeting?
I don't know. That's what we talk about all the time, how we do this, and that was one of the reasons actually to do this early on anyway, because I remember the only one thing that parallels this a little bit is when the coronary Paclitaxel stents had a little bit of a hiccup, and man, it was just like every man for himself, and it was pretty chaotic. It wasn't done in a good fashion. And I think what we're trying to do now is make sure that the physicians and everybody realize that this isn't just being thrown out there and that's it. That's all the data you got. Make your decision. That this is going to be done in a very scientific and rigorous fashion to look at this, to get them answers, and to know that we're looking at it already. And so that if we were already looking back and seeing something that was raising the alarm even more, I think people would be making even faster decisions as far as saying, yes, we should hold product, that kind of stuff. But I think that right now, the big thing is to let everybody know that everybody's looking at the question, industry, regulatory, docs, everybody, so that we're going to do this in a scientifically rigorous fashion so that we can give reassurance of either safety or non-safety, but the decision should hopefully be clear when we get done with this.
But Jihad, the thing is you make a good point. It's more than just Katsano's paper. It's more than just the question of paclitaxel. The question on the table is, sure, we need to answer that question, but can we improve our system, right? Can we learn by what has transpired, as Dr. Ansel stated, in terms of this panic, per se, that's happened, and the end result of stopping 3 large randomized clinical trials because of fear? Is there a way to change our system that we can put safeguards in place such that we don't stop a beneficial technology from being utilized because of a study that, again, and I'm going to say it one more time, is hypothesis generating. It's not a definitive. So, I think the answer at the end of the day from a 30,000-foot view is can we learn from this and change our system as a whole?
Absolutely.
And they even take that one step further, because sometimes, we're still the users of these devices, so we have our own bias, But and to take that even one step further, maybe having even a look earlier that gives us an early warning system so that we're not caught off guard by this as well. So that good or bad, that we're finding these answers in trial designs earlier on so that we hopefully won't have these kind of things happening in the future, period.
Actually, I was going to ask that question.
Sorry.
That was a good point. I'm glad you said it. Industry is always looking at their data every year, correct? They're trying to see if there's any trend going which way or another, and no one has actually have gone up and say I have a signal toward increased mortality. This is as far as I know. And suddenly we get hit with this, and back to you, Dr. Jeff, and you mentioned 2016, and then suddenly you have this. So the industry bias, I think, is going to be maybe not biased because they've looked at their data every year, and they didn't see anything. And so hopefully we see the same when we combine everything together. Dr. Jeff,
Yeah, I think the good thing is that, I think this was said by you earlier today, all of these randomized trials had independent clinical events committees. Their number one job is to look at every adverse event and determine, is it related to the device, the procedure, the condition, et cetera. So every mortality that occurred in these randomized trials was undoubtedly scoured through source documents to try and put a link between the device, the procedure, and the mortality event. I mean, that was the big concern when the IMPACT randomized trial had separation at 2 years, right? And so the reassurance that we all had was that an independent clinical events committee looked at every one of those events and said, we don't see a direct link between the device and these mortality events. So I think you're right, but I want to just kind of not lose the moment as we're getting towards the end here to remind everybody, this isn't about industry. This is all about the patients, right?
Right.
We want to do what's right for patients. We are in this to first do no harm. And like I said, if you have someone who's got moderate claudication and you're not sure about how this is going to play out, you got time.
Absolutely.
But on the other side of the coin, you've got the patient with limb-threatening ischemia where you need durability of a procedure in order to get them out of trouble, save their limb, get them back home, back to their jobs, back with their families. And you're going to now withhold a therapy that's clearly been shown in head-to-head trials to be superior to what we have otherwise, and say you can't use this because of a meta-analysis that generated a hypothesis but didn't prove a question? I mean, I would argue that's just, if not more, dangerous.
Actually, I'm going to take that as your closing statement because this is really well put together. And George, I'll go to you next. How would you summarize this entire?
So to summarize the session, you mean? Again, trying to look at the positive aspects of the session in terms of Katsanos and his paper. I think this is a calling. It's a recognition that we may need to do things better from a 30,000-foot view, a systematic approach to the particulars. Maybe it's trial design, maybe it's understanding exactly what these clinical trials are trying to accomplish. And then once we understand and we do our due diligence, looking at patient-centered data, is how do we interpret it and not jump to conclusions. And then working as a collaborative such that not only healthcare providers understand across our spectrum, but also making sure we relay the message appropriately to our patients, industry, healthcare administrators, policyholders, et cetera, to make sure that we form a unified decision to, again, reemphasize what Dr. Jaff has stated, to the benefit of our patients. That is the end user. So
I like that we always end with the benefits to the patient because at the end of the day, this is who we're working for. Gary, before you give me your closing statement, when we discussed the trials, all of them, there is a common theme saying that the trials were not powered for mortality, to look at mortality. If you can go back in time, would you power these, knowing what you know today, would you power these trials differently?
That's a really good question because not only do you have to look at the fault, is there an answer to that? And the reality of it is you can't afford to do that because these would be huge trials and they would take many more years and they would actually probably never get any new devices because of that. That being said, the thing that we probably can learn from this is our trials should probably go beyond just a device. Because, gosh, how many years do we not have one-year data for many of these things? We were really, flying by the seat of our pants and artists doing things conceptually that were beneficial. Then we got one-year data. Now it's like, well, now you're getting 5-year data on these things, which is really good. But it also means that it goes beyond a device. It's all the different things that can go into that patient care episode as you get longer out that we're going to have to look at. We're probably going to at least have to keep an idea of, did they get treated again? How did they get treated? what were their medicines like, what was their clinical follow-up, so that we want to optimize just not the initial treatment, which is the device, but optimize their care over the long term, which is beyond that.
Absolutely. And today you're going to be leading a discussion on medical therapy, or be part of it. And Dr. Jeff, always go back to you to that. Medical therapy for PAD and CLI actually is definitely underutilized. And is there any word of wisdom here that we can leave for our colleagues that are treating CLI and PAD?
Yeah, so if we're really in this to protect our patients and do the best for our patients, then we got to do better than 18% statin use in patients with PAD and 25% antiplatelet use in patients with PAD. I mean, it's just unacceptable. That, in my view, is way more appalling than anything we're talking about here, where the delta either doesn't exist or is so narrow comparing the thousands of patients. So I think you're right. The good news on the medical therapy side is, for the first time in the last 10 years, there's stuff happening.
Yes. This has been a great discussion. I would like to thank Dr. Ansel, Dr. Adam, and Dr. Jeff for joining us today. And also, I would like to thank our supporters for the educational grant that we received from Medtronic, Cook Medical, Boston Scientific, BD, Peripheral Interventions, and Philips. We appreciate their support for this education grant, and I thank my colleagues for a great discussion.